안녕하세요. 마스터 코스 온라인 라테럴 어프로치 컨벤셔널 테크닉 편을 강의하게 된 연세구치과 김진곤입니다.
Hello, this is Master Course Director and my name is Kim Jin-gu from the Yeonsegu Dental Clinic. I'm going to talk about the lateral approach conventional technique. As you know, lateral approach is the most common way for doing sinus surgery and sometimes it's the only way to do surgery. So I have to cover this in a limited time. So from incision to suturing, I'm going to go through them step by step. So first, what you need to do is before operation, you have to disinfect and you have to do anesthesia and you end with suturing. So I'm going to focus on what are the important steps and others. I'm just going to give you a high-level overview. So the first step is disinfection followed by anesthesia. Before operation, you do a lot of disinfections. And chlorhexidine would be the most popular approach. So through goggles or gauze, you put in chlorhexidine to effectively remove the bacteria in the mouth. So sometimes iodine, like betadine, is used. But skin disinfection might be effective, but it's not often used in orally. And then anesthesia. So to do lateral approach, basically, you have to do block anesthesia. And there are two things to be considered. First is superior alveolar nerve block, and then greater palatine nerve block. And one thing you never should forget is that on the nerve distribution, it's up to the distal buccal root on the upper first molar. So you have to do incision or window opening. You have to also think about anesthesia for nerves. And for the palatine side, you have to do nerve block. And when you have to do incision and have to do flap elevation, you have to consider which side you are going to do them. And one thing I want to also emphasize is that you cannot use short needles. When you do anesthesia, be it upper or lower, you have to, especially on the upper side, we have to do on the upper part, and it can stuck on the zygoma side. So you have to do it with the long needle. So most patients or most dentists do anesthesia in this area, but long needle, more than 70% upper on the vestibule side, that side is the point where you do the anesthesia. So you have to disinfect it and then you have done anesthesia. Then third step is doing incision and flap elevation. So often you use horizontal and two vertical incisions. So let's look into the detail. First, about horizontal incision. You have to approach more palatal than the surgical site. So from the mid-crestal, you have to go a bit toward inside. So because you cannot hold on to the flap, so it's more convenient. And then you use vertical incision. On the mesial, you have to go long. On the distal side, it's better to keep it short. Of course, if it's too short, or the vertical incision margin on the upper side is up to only low on the musical gingiva side, the flap will not be fully elevated. So being on the too long, you should not do it on the distal side. This is very important. This is because of the blood vessels. Like from you have the extraosseous branch of the posterior superior alveolar artery, and on average that's about 23 millimeters. And with the vertical incision, sometimes it's cut. Hence, if it's too long distal incision, then it could cause arterial bleeding. So on the distal side, you shouldn't go too long. On the front side, in most cases, there are not much to damage anatomically. So long is okay, but try not to be too excessive. So again, this is patient on the front side long incision and shorter on the distal side, and horizontal leaning palatal side and circular incision is a must, so that there will be no flap tear, but there will be clean detachment. Then you will open flap like this. The depth of the incision compared to flat will be wider, so it would open more upper side, so sufficiently there will be access secured. So sometimes you use too small instrument, but after opening the flat, Minnesota and Selden needs to be used so that there will be sufficient dissection, and this is much better for good visibility. Next is window preparation. You have to open the flap and the bony wall has been exposed, so you have to do surgery. You have to make window, so you use different instruments. So which side you have to make window is the key, should be key focus. So where would be the best suitable site? I'm not trying to make a laugh, but this is Monk Kungye, and he has a very looks at things very closely. So anyways, if you open flat, you see something that is different. So here, white patent, and it's very smooth, but some other side there is bleeding. There is also some soft tissue that has become detached, and hence you have bone bleeding. So of course there is a borders, and this is where you have to make window. So if you look close, then this side, as there is a border, and color-wise, texture-wise, it's a bit different. That is where you need to make window, like this. So always, you have to look at the panorama picture to see where the window needs to be, and where the lower part of the window needs to be. And if you see very closely, you can know. And one more case, this area, there is bleeding, there is irregular detachments, but upper side there's a lot of more patents. So this is again therefore area where you have to make window. So again, like this very elongated window can be made here, like this. Hence, where you make window, you take CT or panorama photo as a reference to choose the site, but you also need to check intuitively with your own eyes. And that is important. Then exact site, where is a good site? There are different opinions, but I think general view seems to be that if possible, more on toward front side. So on the sinus side, where you want to make window closer to that and closer to the inferior margin, they say it's more favorable. And lengthwise, so for convenience of the surgery, for the instrument accessibility, the distance is set. The height needs to be at least 5 millimeters. Otherwise, the instrument cannot move freely inside, making surgery challenging. So if you're new to surgery, it's better to make wider or bigger window. And once you become comfortable, you make your own may and customize the size to your preference. But again, toward the front and closer to the inferior margin is key, because various perforation on the medial side and here on the inferior side, you see a lot of these things. So let's look at actual case. For this patient, where should we make window? Number 20 is not a good condition, so you have to extract the tooth. So you should extract teeth. Where should the window? If the sinus and inferior margin, then this black area is where the window needs to be. But if you make window like this, if you detach membrane here, there could be some tear. So if possible, the implant on the middle of where the implant will be placed, and the front side, it's better to be closer to the sinus inferior margin. But if you want to take out number 4 and 5, then the distal limit would be extended, and the front part will be the same. But with experience, you can of course always make better decisions. So you make window and membrane exposed, and this would be the borderline for sinus. I don't think this is a best option. If it's closer, maybe it would have been better. But anyway, when you open window, you have to be also cautious of, I talked about when you have distal extraosseous anastomosis and subular alveolar arteries, laceration is something to be cautious. But when you make window here, going through the bone on the sinus side, membrane side, you go inside or you go through the window. There's intraosseous branch. There could be problem there. Actually, all intraosseous anastomosis, it naturally goes through bone at least one. The importance is when it goes through the bone. Sometimes 7 or 9, where there's no window, you go inside like that on the distal side and goes with the membrane, and on the front side it goes to the bone again. Or if you have, sometimes it actually goes through the on the center or the midline side. So you have to check with the CT. But if it happens during surgery, it becomes very hard to see. There could be bleeding, extend the surgical time. So artery location needs to be always checked for the window preparation. That's very important. And I said before, if it's wider window, it's very much visible. But the smaller the window, there is more bony wall on the inside, and it's blocked more from the exterior environment, and the literature said it's better for bone formation. So wider in the beginning, but once you become experienced, it's better. My recommendation is that you make the window smaller. So which instrument needs to be used? So most popular ones would be the straight low speed handpiece and round burr. Sometimes you also use lasket and piezo surgery as an instrument, and sometimes you could also use high speed. But when you ask a lot of people, they say low speed and round burr is the straight instrument. They say it's most convenient and the best option. And for me also, I always use the low speed, of course. High speed bar, sometimes it's clean cut and has a higher vibration, but disadvantage is that there is a curve. So when you access here, cheek or zygoma can be damaged. So it's hard to access very correctly. So it's difficult to apply controlling force. So if possible, I use straight low speed piece. That's my recommendation. There are different sizes. You start off with 4 or number 6, and once become comfortable, move to number 2. I believe is the best approach. And rather than freehand, always use finger rest on the front teeth, and that avoid any slippage or damaging other structures. So again, on the front teeth, tooth, you give finger rest. And vertical, if you go in, there could be tear in going through to the sinus. So again, go from the side. And rather than giving a vertical force, it's better to give side force. And here, with the drill, the wall here, when you open it up, we have to be cautious, step by step, slowly. If you grind in the slowly, then you see the light bluish hue, and that shows that there will be membrane here. And until you see that hue, you go grinding very slowly, like you are painting very cautiously and slowly. And when you see this membrane or the bluish hue, you open it. And if otherwise, there could be difference in thickness, and in window preparation, there could be more damage. So again, window preparation can be in 3 ways. You could do infrastructure technique, folding is involved, or you could be grinding out technique. Everything is grinded out. And lastly, you create good wall and take the wall off, and after surgery you reposition the wall, and that's called wall off technique. In most cases, they opt for the wall off technique. And then when you do window off, there's always window wall, some residual window and then you do green stick fracture to remove it. So when you remove it, you have to be very careful, as you have to careful of the membrane tear, whether you put in the instrument too fast or too deep. So you reposition it afterwards, and you sometimes put this in cell line before repositioning. So why do you use wall-off technique? You have the better access, and even if you're not experienced, it's very easy to get used to that and very convenient to do this. So there are different advantages. And the lateral wall, if it's thick, if you make window you can make windows many times. So wall-off technique that's why it's used. And another advantage, even if there's a septum inside, you can avoid a septum in making windows. And a septum, if it's long, then on the upper front side or the back side, you can separate them in surgery. And if there's a big septum like this, you can detour it and dissect it and meet in the upper part. So even if the septum is high, there's no problem in doing the surgery. And it can even create one big room or window. So number 20 was extracted for this patient before surgery, and as you can see here, there's a high septum, and it's very hard to treat them. You have to do surgery, and so you cannot do simultaneous placement implant because there could perforation when you try to treat the septum. So carefully you make a big window and dissect on both sides. And if you do that, you can create one big window, and sometimes it's better for membrane elevation. So with there's a state handpiece advantage just like this. So inside you fill it with the bones and do operation. If it's a low septum, then you can ignore it. So there's a septum, but it's not too high. And on the inside, as you can see, there is a bigger transverse septum, and for this patient, therefore, you open it up big, treat the septum, and perforation is also handled, and you fill it up inside. And on a long-term basis, you can see there's not much of a problem. So I'm telling you this and sharing this case because the biggest concern in lateral approach is how to make a window and what to do about septum. So special instrument, and you might say could be the answer, but frankly the best way is the roundware and state handpieces can be used so that you can handle any cases in operation, and once the experience build with different types of operations, you can do it much easier. And as I said before, there could be bleeding, and this side, if there is a bleeding, always make a window. And when you make a window, this area that is inside, there could be a lot of bleeding, so you have to be mindful of that. Sometimes you can find everything on CT. So like this area, you have to see it keenly with your eye and see this could be a bleeding potential, so avoid this area. So you have to be mindful of these possibilities always. And I said before, from alveolar cleft, they say it's 16 to 19 millimeters. So that's what's often said in journals. But it's different from the window shape. If there's a lot of bone resorption, or if there's a lot of, the sinus coming down, then actually from the residual bone crest to artery, the distance is that determined with that. So you have to be careful and mindful of different things. Next is about membrane elevation. You have to make window, and you have to push in the bone after elevating the membrane. The membrane tearing is something you should always be avoided. And another thing is color and thickness, and whether there is a cyst and pathological condition. Always needs to check through the CT before operation, and also check after making the window also. The first thing you need to do is if after assessment you have to separate the member. So a separator, like this type of instrument, like when you push something down, this round plate can be used. So you put that in the margin and round it up, then it can be cut very easily. So you only cut it on the kind of the border area, and after that, for your elevator, we can lift the sinus side. This special instrument can be used. That's curved by 90 degrees. You can do elevation. So there are different Ostem instrument with such angles, and it's very easy to use. This one is better for the medial side where the instrument cannot reach very easily. So there are various convenience instrument to be used from Ostem. So the step is very important. You start off with the distal side, and then floor side is the next one. So this will be number 2. Next will be on the mesial side, and lastly, once everything is all off and it's a bit there's less tension, then you go palatal or the medial side. So from the beginning, if you start with the medial or palatal side, there's a lot of high tension. So from closer to the wall, where it's easier to access, and from membrane to bone, the connected strength is the lowest area. Hence, distal area should be your starting point. So always from distal, then floor side, then your anterior side, and then lastly palatal side. So the important thing here is this instrument. If it's on the air, it should not be the way. Always it needs to be kept in touch. The edge side should always be in touch with the bone. If you push it like this, inevitably there will be perforation. So again, the edge or the tip should not be pushing inside. It should always, the tip should always touch the bone. Like if you create a crest on the pan, it's better to go inside, like this direction, to take things out. So how much elevation? There are different theories, but many agree that the bony wall, if it's the more the bony wall, the more favorable area it is for bone formation. This means that rather than this case, like this, full detachment, so securing more the bone surface is better for the bone blood supply and cell supply. Hence, it's more favorable conditions for bone formation. And again, always too little on the palatal side. It really happens for me also, frankly. But rather than that, consistently elevation that is on a consistent level throughout is important and better. Now, do you put in bone? No, if you have done membrane elevation, then you have to do drill to place implant. So you prepare the implant site, and then you put in bone and then place implant. So there are different approaches, but as you know, on the upper area, the bone quality is favorable on the posterior side. And if there's a lot of bone loss on its extracted side, then the bone density would be weak. So the recommended way would be smaller final drill needs to be used for the final preparation. That's more favorable in terms of result. So here it's including the casket. So to put in 4.0, you only need 2.8 to 3.1. Of course, on the lower posterior, it might be not sufficient. But if it's less bone quality and the bone height is low, then you have to think about the stability. So you should not drill too excessively. And when drilling, sometimes you get stuck on the adjacent teeth, especially number 20s. Sometimes there's a lot of block. So the path might be ruined when you want to place the implants on the left side. Possible you use drill extension or use long drill. That's more will get you favorable result. And after sufficient detachment, even the drill tip is touching this area, there will be not much perforation. So enough detachment guarantees no sinus membrane perforation. So enough detachment is important. Next is bone grafting. You have to put in bone, and to bone in there are different, of course, ways, but we are talking about lateral approach here, so we'll go laterally, and there are different types or volumes that's involved. But in this lecture, I cannot cover everything, so we have separate lecture on that, so please reference that. So if you put the bone in, then you have to place implant. And when you place implant, there are different theories. So you could have staged approach, or you could have simultaneous approach. So is it better to wait in staged approach, or is it do it at the same time simultaneously? There are different opinions. This paper came out in 1998, and it's related to this is the first consensus conference report on sinus surgery protocol. So this was protocol created in 96. So if it's 10 millimeters, it's not much of damage. And if there's that much of residual bone, then use sinus floor elevation. And if it's like this, you can do simultaneous. Or if it's 1 to 3, then you have to do delayed approach. But my experience tells me, and considering different factors, if you can place implant, if there is instability to be gained, I prefer doing simultaneous placement. If you look at this literature, and which is from Fukazoto, if you have less than 5 bone height, 510 implant, success rate was 97%. So there's no problem in doing simultaneous placement. So for this type of height, even if this augmentation placement, success rate was still 100%. If you look at this journal, this is a systematic review, so it's more credible. So simultaneous placement, success rate, compared to the delayed placement success rate, as you can see, there's not much of a difference. Hence, so again, there are different opinions and residual bone height and both success rate. What's the relationship? If you have more than 3 millimeters, that decreases success rate, or some say there's no relationship. So there are different opinions, but in my personal opinion, I think initial stability is one of the most important factor. So if you have sufficient initial stability in the implant side, if you have good fixture and good operation skills, then I do not believe there will be a lot of issues. So I think primary stability is the key. Without primary stability, there could be problems. So using good instruments, you can avoid issues and gain primary stability. So again, like this. And if bone is formed, then there could be stability going up. So again, by the 3rd or 4th week after operation, there is a stability dip where the stability becomes the lowest, and that results in a lot of implant of failure. So again, if you cannot gain primary stability, it's better to have staged approach. But if you have initial stability, then you can have submerged, and there could be successful result. So if initial stability is there, then I go with the simultaneous placement. So for this wide or this pitch fixture is used, then on the upper sinus area, you can gain more primary stability. So use this type of instrument. So this windows, you put in Z line and store it, and you can reposition it later. So if there is too much grinding, or sometimes it's disappears, then if possible, it's better to cover it with membrane. But sometimes they say you should not do nothing, let it be. So which is better? They compare the two, but in conclusion, they say without lateral wall covering, the success rate actually meaningfully went down. So that's why I'm sharing with you this data. And this literature also says that same thing. So the covered group and non-covered group, as you can see, there is a significant difference and meaningful difference of the success rate. So if there's no wall, if it's fully grinded, then it's better to cover. The last step is suturing. As for suturing, the two vertical incisions and one horizontal incision, and this area you have circulations, then you have to suture everywhere. But the most important thing is mesiodistal corner side. The key suturing, if you do it well, then flap will be fixed in the position. After all suturing, if you want to do mesial side, but the flap, there was a displacement and you cannot cover the front side, that would be a problem. So with the suturing, unless you do GBR together, the buccal flap extends a lot, so the flap it always can be covered, and flap tension is not really that much a problem. But there is a key positions that you need to consider that I pointed as before. So you have to be mindful there, and the most important thing is to these areas needs to be very carefully considered to avoid flap displacement. So if you look for these areas and do that area suturing well, then there will be no flap displacement. So what happens after sinus grafting? Be it sinus graft or GBR, in the beginning it becomes a bit acid. You have blood clot and platelet and fibrin, and there will be no vessel as of yet. So bone graft material and platelet would create blood vessels, and cytokine that's been formed inside would start the remodeling path. And then after day 7, the vessels newly budding, the capillary small vessels would be created, and microfunge also happens. So a lot of destructive activity happens, and on the stem cell side, there's osteoblast divided cells coming in. So here is where there's a lot of osteoclast activations. So during this time, you have this type of different activities, and by day 14, after 2 weeks, osteoblast activated, creating new bones, and by that time, pH becomes normal, and blood vessels will supply blood. This means up to 2 weeks after operation, it's acidic and in the sinus area, and because of that, there's not much blood supply inside, so it's very vulnerable to the infection. So more than a week, antibiotics and other things need to be used to protect this area. So suturing needs to be thoroughly done, and the surgery should be traumatic. So there are different things like this to be considered. So that's my lecture for today. A lot of details are prepared, but I think you can learn about that in my offline lecture. Thank you very much.